Greetings, everyone. I'm Captain Pankaj Pahil. With 17 years under my belt training pilots all across the globe, I'm here to guide you through the absolute intricacies of the DGCA syllabus in today's explainer.
You know, they always say the sky is unforgiving to the unprepared, and it is absolutely true. Discipline is quite literally the exact bridge between a student pilot and a safe, resilient captain. So, welcome to today's ground school session. We're going to take all that raw textbook medical data and we're going to translate it into pure muscle memory for the flight deck.
All right, looking at the boards, we have a strict zero-skip policy today as we dive into 5 high-stakes threat zones. We're covering altitude and pressure limits, decompression sickness, the cockpit environment, in-flight incapacitation, and finally, those crucial licensing rules and mnemonics. Now, looking at this gauntlet roadmap, conceptually, what we're talking about here is your actual operational survival. In the real world, these aren't just textbook pages, they are interconnected flight deck scenarios. So right out of the gate, here's your main exam tip. You absolutely have to memorize the specific numerical thresholds for each of these waypoints. You've got to study them as one complete interconnected system. Let's jump right into Section 1, Altitude and Pressure Limits. The core theory here, time of useful consciousness, or TUC, is absolutely critical. Now remember, TUC is not the time it takes for you to actually pass out. It's your functional time. Up there in the aircraft, your oxygen mask has to be on before this window expires, because once it does, you literally cannot take corrective action. For the DGCA exam, pay close attention to the curve on this graph. See how the time just drops off an absolute cliff right above flight level 250? That is the danger zone. Moving over to the master table, you can see how this data builds. And listen, the DGCA expects you to know these exact regulatory figures, the ones in blue, verbatim. So look at a typical jet transport cruise altitude, say flight level 350. At that altitude, you've got a maximum of just 33 to 54 seconds of normal TUC. Think about that. That is barely half a minute to recognize the issue, communicate with your crew, and get that mask securely on. But here's the crucial point. What happens when things go from bad to downright worse? I need you to burn this red critical safety rule into your memory right now. A rapid decompression will reduce your time of useful consciousness by exactly half. Why? Well, because a rapid decompression doesn't just drop you to ambient pressure, it actively sucks the oxygen right out of your lungs and into the cabin atmosphere. So if you had, say, 33 to 54 seconds at flight level 350, suddenly you only have 15 to 30 seconds. It's a massive game changer.
All right, moving on to Section 2, Decompression Sickness, or DCS.
This soda bottle analogy brilliantly illustrates the physics of what we're dealing with here. The DCCA syllabus actually utilizes this exact concept to explain Henry's law. Basically, when pressure falls abruptly, specifically when the atmospheric pressure is literally cut in half above 18,000 feet, the dissolved nitrogen in your body starts forming these really dangerous bubbles in your tissues. It's exactly like taking the cap off a shaken soda bottle. Cap comes off, bubbles fizz up. It's that simple, and it's that dangerous. So, applying that physiology, those trapped nitrogen bubbles track into different systems of your body, causing what we call the BCS syndromes. Bubbles in your joints, that causes the bends. Bubbles under your skin cause the creeps. In the respiratory system, it causes the chokes. And bubbles reaching the brain cause the staggers. Now, notice we've marked staggers in red critical text. That's because this neurological form of DCS brings on immediate confusion and paralysis. It is absolutely the most dangerous form you can encounter. So what do we do about it? Your top exam tip here and your green standard operating procedure for treating literally any of these syndromes is the Woodle M sequence. Let's break it down. Step 1, keep the patient warm and on 100% oxygen. Step 2, initiate an immediate descent. Step 3, land as soon as safely possible. And step 4, seek medical aid immediately upon landing. So that's warm and oxygen, descend, land, and medical. WODLM. Make sure you memorize that. Next up is Section 3 of the cockpit environment. We're looking at the silent fatigue generators. The core issue we're facing here is that extreme cockpit temperatures will seriously degrade both your fine motor control and your cognitive function. On the flight deck, your optimal conditions are 40 to 60% relative humidity and exactly 20 degrees Celsius. Anything above 30 degrees, that's going to trigger heat stress. Now here's a massive takeaway for your test. The native air in a jet cabin is inherently incredibly dry. And because of this, you really have to avoid diuretics like coffee and tea. I know, we all love our pre-flight coffee, but it literally just worsens the dehydration. Now, let's talk about vibration. For your exams, you need to memorize these specific regulatory resonance frequencies marked in blue. Your skull resonates between 1 and 4 hertz, which, you guessed it, can cause some serious neck pain. The torso sits between 4 and 10 hertz, but I want you to pay extremely close attention to the 30 to 40 hertz range. Why is that one so critical? Because that specific frequency actually resonates your eyeballs. It's going to severely blur your vision and completely impede your ability to scan the instruments. All right, that brings us to Section 4, In-Flight Incapacitation, covering critical medical emergencies. At its very core, an in-flight incapacitation is a direct, immediate threat to the survival of the aircraft. And honestly, your only true prevention measure for this is your periodic aeromedical exam. So if you want to ace this part of the exam, you need to remember the 6 attributes of the SUPCF acronym. Just remember, incapacitation is sudden, unpredictable, unavoidable, prolonged, complete, and it's potentially much more frequent when you're in a high-stress flying environment. Take a close look at the comparison here between obvious and subtle incapacitation. You'll notice the red critical warning right away. Subtle incapacitation is actually far more dangerous. You might wonder why. Well, with an obvious incapacitation, the pilot visibly collapses, right? You immediately know you've got a major problem on your hands. But with a subtle incapacitation, the affected pilot appears completely 100% normal, even though their judgment and their responses have completely failed. Visually, sure, they're sitting right there in the seat, but operationally, they are completely gone.
And finally, we've reached Section 5, Licensing Rules and Mnemonics. These are your regulatory hard stops.
The fundamental medical distinction we have to make here is between an electrical disturbance in the brain, like a seizure, and compromised blood flow, which causes fainting. As a professional pilot, it's absolutely crucial that you can recognize the warning signs of a faint coming on. Things like lightheadedness, dizziness, sudden muscle weakness. You need to spot those early so you can take immediate preventative action. Now, your critical exam tip is this rigid decision tree right here. Listen to this. Any fit whatsoever, whether it's a major grand mal or just a minor petit mal seizure, is an electrical disturbance that causes an unpredictable loss of consciousness. Because of that, it is an absolute bar to holding a flying license. On the flip side, check out the green text. Syncope, which is just a medical term for a faint caused by heat, shock, or hunger, actually has no significance to your license whatsoever. As long as the underlying cause is clearly understood by your doctor, you're fine. The golden rule to remember: fits are forbidden, faints can fly. Let's move right along to our wait to fly rules. To really cement this into your muscle memory, we use the 12, 24, 24, 48 timeline progression for mandatory grounding. It's a progression, so each step gets a bit longer. First, you absolutely must wait 12 hours after experiencing a rapid decompression. Next, you gotta wait 24 hours, from bottle to throttle, after consuming any alcohol. You also must wait 24 hours after any compressed air scuba diving below 30 feet, just to give that nitrogen time to off-gas. And finally, you have to wait a full 48 hours after a blood donation to properly recover your red blood cell mass. So again, that's 12, 24, 24, 48.
All right, before we wrap up, I want you to look at this final scenario. Try applying the 24-hour rule and Henry's law that we just covered. If a pilot dives down to 40 feet, well, they've obviously crossed that 30-foot threshold, right? So if they try flying after only 12 hours, they are flat out breaking that 24-hour mandatory wait rule. And what's going to happen? The reduced pressure up in the cabin is going to pull that dissolved nitrogen straight out of their tissues, forming bubbles and triggering a lethal case of decompression sickness. So what's the big takeaway here? Don't just memorize these numbers, internalize these scenarios. That is exactly how you leave this explainer fully ready to go and conquer your DGCA exams. Study hard, fly safe, and I will see you all in the next session.